You're winning. You're winning. You're winning. You're winning. Welcome to another fabulous episode of Epic Understanding. I am your host, Coach Love. I am so excited about the guest we have here tonight. Quite frankly, she has healing hands and a healing heart. She has a career that spans from helping veterans to helping everyday folks like myself right in our homes to help take care of our loved ones. There are so many pitfalls to the healthcare industry today, and she has come to educate the masses on how not to be a victim of the healthcare industry. Welcome, April. How are you?
Hi, Erica. Thank you for having me. I'm so happy to be here today.
You know what? Your warmth and your love and what you do for patient care is amazing. I don't know where that affection comes from, but I'm glad you have it.
Thank you. Thank you. I just like to say, I always tell people I am my father's daughter.
Oh,
Always grown up to do exactly what I was taught as a child, and that is just to do right.
mm-hmm.
And when you do right, things seem to always line up in the right place at the right time. So hopefully I'm here to share information that's helpful and practical to people's everyday life.
You want to know something? You said you are your father's daughter, and I always say, I am my mother's daughter. Oh, we have that in common. The
Yes,
apple doesn't fall too far from the tree, isn't that right?
yes, absolutely, absolutely.
Yes and amen. Now, I have to pull our cover back up, right? Girl, listen, look at this cover, okay? Um, Healthcare hell, it's like kind of grabs you. Hopeless hospitals, nursing home nightmares, hollowed out home care. Actually, I would like to for you to speak to your thoughts on each one of those areas in general. And then I also want you to kind of explain some of your credentials because obviously you are a registered nurse, but I see BSN, MBA, CWCN, which is really the one I want to focus on as far as the explanation goes, because the other ones are a little more common. So please share with us a little bit about your background and credentials.
Sure, I'll be happy to do that. Well, like many nurses, nursing is a second career for me. I spent
Okay.
many years in the banking and finance industry, and one day just decided that I was going to follow my passion, like many other individuals in my family, and become a nurse. So I actually had the MBA before I became a nurse, but it actually helped me be a better nurse. So
I
I've been
see.
a nurse for about 15 years, and I've worked in various settings within the acute care and critical care setting, as well as in the skilled nursing and long term care setting in nursing. Uh,
Mm-hmm.
and coupled with that, I became a certified wound care nurse. Now, my certification in wound care is with the WOCN, which is considered the gold standard of wound care certification because it is the only wound care certification that requires you to have at least, well, first of all, it requires you to be a nurse and it requires you to be at least a bachelor's trained nurse. So this certification really prepares you to deal with wounds in the acute care, critical care, uh, long term settings where you're really dealing with wounds uh, that are assisting physicians with healing wounds that take a long time to heal. Now, in the area
Right.
of wound care, there's not a lot of wound care nurses in the country. There's only about 6,500 of us in the country, and not a lot that look like me. So there's only
Mm-hmm.
a few hundred of us, African American wound care nurses. And in my area, there's only about three African American wound care nurses. So I'm really happy to provide this service to people of color who have a lot of challenges with chronic chronic wounds.
I see. I see. That is excellent.
So, in speaking to wound care in general, it is a field that's very challenging for individuals that are in nursing homes because I know most
Mm-hmm.
people have heard about pressure injuries. As a matter of fact, some people say bed sores, pressure ulcers. In the um, formal phrase, we call them pressure injuries because it is an injury.
Mm-hmm.
Because people who are in the hospital settings should never get pressure sores or pressure injuries. Uh,
Mm-hmm.
so in the long term, in the nursing home settings and dealing with pressure injuries, uh, you have to really be careful when you're assessing a patient's skin and you're turning patients. And a lot of times, nursing home staff or they're very understaffed, so they really occur pretty frequently in nursing homes.
Well, and is it ever acceptable for in any kind of medical setting for your loved one to actually get a pressure sore?
Well, when you deal with pressure sores in general, and I'll call them pressure injuries because that's
Hmm.
exactly what they are. They are injuries.
Yes.
Um, it is. There are occasions in the formal setting. There are pressure injuries that sometimes will occur in patients, and they
Hmm.
call those unavoidables. But those patients are really, really sick. They sometimes they're intubated, they're put into positions where you can't turn and reposition them because their life is compromised. Meaning, if you turn the patient, they may their heart rate may drop, the breathing may become compromised. So there are some instances where you just can't turn the patient. However, those instances are very rare. So in most cases, pressure injuries should not occur.
Okay. Okay. Let's back up just a little bit because there are three areas that I want to talk about. I want to talk about hospital care, nursing home care, and then home care. First, let's start off with hospital care. Specifically, it seems that nowadays um, you get put in the hospital and they want to put you right back out as quick as you were in there, um, even before you're healed or you have a accurate diagnosis. What's been your experience with that?
Well, medical advances, uh, we've had a lot of medical advances that don't require people to be hospitalized very long.
Okay.
So the intent is that people can be hospitalized for a short period of time.
Mhm.
And there is a lot of care that can be provided in the home.
Mhm.
However, when you look at the quality of care and you look at whether those patients are successful when they get discharged, you really have to make sure that you do specific care planning and the patient has specific goals when they are admitted in the hospital as well as when they become discharged, because what frequently happens is if those patients are discharged too early, they
Mhm.
end up right back in the hospital, and sometimes they end up right back in the hospital. It could be days, it could be weeks after their discharge. And unfortunately, we have a term that we use for these patients. We call them frequent flyers, which is probably not
Mm.
a nice thing to say, but if you really look at the historical conditions that they have, because sometimes they have chronic conditions that where patients do become hospitalized frequently, and those conditions could be hypertension, heart failure, chronic kidney disease, that those patients, when they reach a certain point in their disease process, they do become hospitalized more frequently. However, if you look at the process of their discharge planning, if the system is not providing them with those adequate services, then they end up going home, and it's an unsuccessful discharge, and they end up right back in the hospital. And a lot
And
of times the family members are not even equipped to assist the patient with some of the care that they need when they get home.
so that's what I like about your work. What you are passionate about is helping people get equipped to ask the right questions to
Absolutely.
exactly to either challenge whether or not their loved one should be released or accept that they should be released and then prepare for the next transition. So, what are some questions that people can ask in a hospital setting to find out if it's the right time for them to be released?
Well, if you're looking at a patient who is chronically ill, and
Mm-hmm.
they're going to have this condition with them when they go home, one
Mm-hmm.
thing you have to make sure is that the patient's medications are sufficient. Because what often happens when the patient is hospitalized is their medications that they take when they're in the hospital is going to be different from the medications that they take when they're at home.
Okay.
So, and sometimes they don't even have the same doctors that are seeing them when they're in the hospital than when they're following them when they're at home. So you have to make sure that those medications are in balance. So the same medication that was sustaining them when they're in the acute care setting may not be the same thing that they were on when they're at home. So when you get the person home, most people are going to look for those same bottles of medication that they were taking before they went in the hospital, which is different than they need to help sustain their health. So you have to look at making sure that their medications are correct, or if there's been any changes in those medications, that they get updated when they get home. Uh,
Okay. So it sounds like what you're saying is take time to review the medication list upon discharge.
Absolutely. Absolutely. And if you are the one who's going to be assisting your loved one when they do get home, personally, you have to make sure that you have the training
Mm-hmm.
to be able to assist them with whatever their needs are. Sometimes when patients are discharged, they don't have the same level of mobility.
Mm-hmm.
They're not able to do the same things that they were doing prior to their hospitalization. And if they were hospitalized because of a particular wound, then you have to make sure that you're able to do the dressing changes, or if the patient is going to be doing that for themselves, that they have the adequate training. And believe it or not, one of the most frequent reasons where or where patients return to the hospital, to the emergency department, is because they are discharged without wound care supplies, even
Mm-hmm.
something as simple as a band-aid. So if you're in the hospital and you have surgery and you're supposed to put a band-aid on every day, and they forget to give you band-aids, a lot of people can't afford band-aids. So what
Mm-hmm.
do they do? They're going to go back to the ER because they're going to say they forgot to give me band-aids. So you have to make sure that even the simple things are, uh, I mean, we always use the phrase, dot the I's and cross the T's.
Mm-hmm.
Those details are so important when it comes to your health care.
And sometimes, not always, but sometimes if it's medically necessary, some insurances may cover those wound care supplies.
Absolutely. If your wound, and obviously I'm not a insurance expert, so it's
Mm-hmm.
always good to ask the questions, and they do have experts in the hospitals. that can assist you with that. But in
Mm-hmm.
most cases, if you're hospitalized because of a wound issue, the majority of those supplies will be covered. Now, if the particular supply that they're using in the hospital is not covered, there's usually a close substitute that is going to be covered by insurance. So
Mm-hmm.
you have to ask the specific question if it's something that's real complicated. For example, if your wound requires you to have negative pressure wound therapy, which some people call a wound vac,
Okay.
you have to make sure that that's going to be covered by insurance. Well, there's all different types of wound bags. There's,
Mm-hmm.
the KCI Active bag. There's a Freedom bag. There's incisional wound bags, and you have to make sure that those products are going to be covered by insurance. And and if you're using a product that's that complicated, then you may even require a home health practitioner to place that wound vac in your home. And if that's the case, then you would require a home health nurse. Now, if you're going to have a home health nurse in the home placing a dressing as complicated as a wound vac, then maybe that home health nurse is able to provide some other services while they're there, since they are a skilled nurse provider.
Mm-hmm.
So you have to be thinking about a 360-degree um, toolkit for your loved one, not just one specific thing when it comes to their health care. It's almost like you have to go in with a plan for what all their needs are and think about, things like transportation. Do they have a ride home? If they don't have a ride home, maybe the hospital can provide a ride home. Uh, do you have stairs in the home? If you have stairs in the home, maybe they need physical therapy to help them
Mm-hmm.
get stronger. And these are all things that can be arranged while they're still in the hospital. So you don't want to wait till after they get home to find out they need all these things. So these are some of the things that you need to be assessing while you're visiting them every day. And I always tell nurses when I train them with wound care, because there's um, nurses kind of think it's so hard to do skin assessments when you have to do IVs, medication, and you have all these responsibilities to do your nursing care on a daily basis. I always make them think about wound care and skin care is done at every point of contact with the
Okay.
patient. So when you go visit your loved one, you're asking them all these questions. You're asking them, how did you eat today? Do you still have your dentures? Uh,
Mm-hmm.
did you have a bowel movement today? Did you get a bed bath today? And you're the loved one, but you're also providing care to
Mm-hmm.
yourself. Even though you might not be physically doing it or laying your physical hands on the patient, you're planning every single time you go to visit your loved one, or even when you talk to them on the phone, you're doing FaceTime. You're asking them all these questions because you're planning for eventually them to come home, and you want to make sure that they have a successful discharge and you're able to provide the services that they need when they go home.
You are right. And there are a lot of best practices. The reality is, we have to remember that the hospital begins to plan their discharge as soon as they admit them.
Absolutely, absolutely. That is correct.
And so we want to be talking with the social worker.
Yes. So when you think about one of the things that they teach us about nursing, or I should say within wound care, we're
Hmm.
always thinking about a team. And
Okay.
within our team, we call them interdisciplinary teams. When taking care of every single patient, there's a team that's gonna be involved in their care. You're gonna have your physicians, your social workers, your dietitian. If they have a special need, for example, a specialty provider or a surgeon or a cardiologist, or if they need physical therapists. In my particular case, may even have a lymphedema specialist. These are all the individuals that you might want to talk to If you have a loved one that's in the hospital, you want to talk to their team, because each person in their team is going to have specific information about what the care needs are for your loved one, and they're going to help you build a case if you have situations where perhaps insurance doesn't cover something, where you can say, for example, if insurance doesn't cover physical therapy, you can say, well, while I was at the hospital, I talked to the physical therapist and they said they couldn't do steps. So now you have just as much information. You have just as much information as the hospital had to help secure those services for your loved one.
Mm-hmm.
And you also have to know that as the provider or as the caretaker uh, for your loved one, you have just as much rights as they have. Of course, there's durable powers of attorneys, and you have to get the proper paperwork in place. But once you have that established, you can talk to these individuals frequently when you're at the hospital, uh, or even if you call the hospital to get those services established for your loved one.
Absolutely. And one thing I wanted to highlight is in order to get many things covered by insurance, there has to be a prescription. Unfortunately, the doctors will often tell you you should get your primary care doctor to
Absolutely.
write that for you. And then when you call the primary care doctor, they say, they didn't write this for you in the hospital. Well, we can't get you in until XXX time, or they might not be familiar with how to write it appropriately. Okay?
That's a good point. It's some things in the hospital, let's just be honest, physicians don't know.
True, true, very
And,
true.
and I'll give you a good example. In the case of wound care,
Hmm.
there are only, and don't quote me on this because if somebody does and writes me, I'll tell you I don't know the exact number, but there are very few medical schools that offers didactic education in
Hmm.
wound care. So that's why wound care in general is a nurse driven practice.
I
So
see.
most of the wound care recommendations, supplies, all that information, even if you look at most of the books about wound care, most of them are written by nurses. So if you understand that, and you understand that physicians don't know everything, so sometimes you have to assist them with connecting with the right physician to get the services that you need. So if one physician is saying, well, go ask this physician or go ask that physician to get what you need, nurses go through the same thing when we're advocating for patients. They'll tell us, well, call the cardiologist, call the nephrologist. In the end, you have to be able to articulate the exact needs of the patient and be steadfast to make sure that whoever is responsible for delivering those services can get that done for the patient. And sometimes that's the primary care provider, and sometimes it's a specialty provider. And in the end of the day, sometimes you may have to uh, go to patient advocate because they need to determine how that's going to take place for the patient. But I guess I've always been the type of person that I don't always take no for an answer. And when it
Hmm.
comes to your loved one, I'd say that that's probably okay
Hmm.
because uh, if you sometimes you don't know what to ask for, but I would say that in most cases, if you're asking for things that are reasonable, you can always find a way to make it happen.
And I just want to be honest and say, sometimes the staff will think what you're asking for is unreasonable. And they honestly do not know what services are available to you or what you should be having. So, as a patient advocate, as a person who's visiting, you have to almost think of yourself as a part of the team, an advocate for the patient, and the person who's trying to connect the dots. I hate to say this. My mother, um, was in the, has been repeatedly in the hospital over the past year and a half for long periods of time. And I would sit in the hospital from, sun up to sundown. And what I truly noticed, and the reason why I would stay so long, is because I noticed bad information would be passed through shift change. So they would provide one another with bad information. And then um, they would, people would not have, one person would tell me something was possible, and another person would tell me it wasn't possible. Um, and it might be something that my mother would really need. So I found myself needing to give her full time advocacy. And then the reality is, there were so many times that I was there that because my mom, she had gotten to the point where she didn't feed herself, so she couldn't speak her needs. So if you have a person that's in the hospital that's not able to speak their needs, they might just, put the tray in front of her and run off, not intentionally,
Absolutely.
but
Absolutely.
but they get a call light. So I'm not saying that they don't care. I'm not saying that they're not loving. What I am saying is that they're only one person.
Absolutely. Absolutely. And that is a reality in healthcare. There is a nursing shortage, and people get busy.
Mhm.
There are unintentional things that happen. So I
Mhm.
can't say that it's a perfect world, but the more you are involved in your loved ones' healthcare, the better outcomes they have. And that is what they call in nursing evidence based.
Mhm.
Um, so you are correct that those things do happen, but being an advocate for your loved one, you will have a increased um, opportunity for that person to have a better outcome. And you have to arm yourself with information. There are a lot of things that you don't know, but once you understand that there's an area that you don't have information in that area, I mean, just like there's the internet, there's all
Mhm.
types of resources out there. There's resources at the hospital. Most hospitals, especially the larger ones, they even have a whole library, so you can use those resources. Because I know you and I talked about uh, the film scores, and you had
Yeah.
to learn what that was, and to help you get a better understanding of that whole area of uh, nursing home care. So you have to arm yourself with the information, because the better you do that, then the better opportunity you'll have with your provider to get a higher level of understanding about what's going on with your loved one. And I'm going to say this, more attention.
Mhm. Absolutely. And I just want to highlight this particular area just because it was actually a life and death situation for my mom. But transition points. Anytime your loved one is being moved from one place to another at all, even if it's from one floor to another, I'll give you a quick story. When my mother first got sick, they had her in ICU. They moved her from ICU to the surge floor. Now, while she was in ICU, she had been incubated, so she had not eaten. Okay, they took her down to med surge. She was waiting to be um, examined. Um, when I walked in the room. This was during COVID, so the hospital was not letting you in, like at a regular early time. So they were let me in about 10 o'clock. At that point, I just noticed the way she looked, and she just had a look as if she was strained. I said, "Has she um, has she eaten?" And I got kind of like blank looks. I said, "Can you check her blood sugar?" Her blood sugar was 55.
Uh,
55. 55. Now she's already in a weekend state. And this was the response I got. Well, the nurses didn't take her blood sugar because the doctors didn't order it. The doctor didn't order it because the nurse didn't tell her that she looked weak. Ay, 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 ay. You know, um, it was just a very difficult a moment in time. And quite frankly, had I not came in there and start calling the nurse like bug, 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 it took from the time that I called them, it took them a whole nother hour to actually get in there. And it took me walking out of the room several times to go and uh, get them. Now I realize this is the time during COVID, but that could happen at any point. And I could give you several stories that every time there was a transition, moving for her from one floor to another, or one room to another, or from um, in like a hospital care to like a nursing home rehab care or rehab care period, a lot of investment had to go into um, just um, how that was done. Um, it's a really really big deal for sure.
Absolutely, absolutely. And as we stated, arming yourself with information and just taking that opportunity to really understand what's going on with your loved one does go a long way. And I'm glad that you were able to get the assistance that she needed.
You know
Yeah.
what? I am thankful, but truly I have to say it's to the grace of God. I have when I tell you I have story upon story upon story. Um, I in Missouri, bed rails are a no-no. It's considered a restraint.
Restraint. Yes,
Mhm.
yes.
Here recently, the last time my mother was in, they transitioned her from the hospital to um, what I'm going to say, what turned out to be a very nurturing, loving facility, but the ambulance dropped her off at the facility, and they put her in the bed. When they put her in the bed, they put her in the bed like this, and so um, I had actually followed the, ambulance there, but they got there faster than me because I had to still pack up her room or whatever. Um, she was hanging out of the bed. I was like, oh my God. And who knows how long she would have been hanging out of the
Yeah.
bed.
Yes.
They didn't have any bed rails. They didn't have any what they call halos on there. My heart was falling out of my chest because she was this close from onto the floor, onto the floor, and they are an award-winning U.S. News um, facility. So it wasn't that they were a bad facility. It's just that by happenstance this could have happened to her. So it's just so difficult. I want to talk about um, the level of care one can expect from being in a hospital to being in a nursing home because oh my God,
Yes.
that is
Yes.
so different, right?
It is. It is. And there's different types of nursing homes. There's one where skilled nursing, where patient may go for a specific need, such as a wound where they're seeking to heal up, or they may have had a stroke
Mm-hmm.
and they're going to get rehab,
Mm-hmm.
or they may have a lot of functional needs or need care, uh, and where the family is not able to provide care, and they have to stay there on a long-term basis. So there's what they call skilled nursing, short stay, and then there's long stay facilities, and there's facilities that are called long-term acute care
Mm-hmm.
facilities where a patient may be intubated or have a high level of functional needs, um, where they're not necessarily unstable enough to be in a hospital, but their care needs are so high that a nursing home or even a long-term care nursing home would not be able to provide those needs.
Mm-hmm.
You would have to look at what the patient's functional level is and what their care needs are, and then they would determine whether insurance would pay for
Mm-hmm.
their stay, or if the family is private pay, then it's a whole nother episode that we'd have to discuss
Wow.
here. But in terms of a skilled nursing facility, if they're just there for rehab, then most of the time that's going to be limited to maybe 4 to 6 weeks.
Mm-hmm.
And the
If
patient
you're
would
lucky.
and the patient would need to be meeting certain milestones within those 4 to 6 weeks. So they would have to show a specific level of progress for them
Mm-hmm.
to be able to continue to stay at that facility. And if they're not meeting those milestones, then the insurance would discontinue paying. So, and if the family is not able to provide that care for the patient, then they would have to enter what they call long-term care, which is where the nursing home would provide for all of their functional needs. In some cases, their toileting, their feeding, all the meals, which are the basic needs to sustain your activities of daily living. Yeah.
Mm-hmm. Mm-hmm. And a lot of it goes into what kinds of goals that are set for your particular loved one. Sometimes, if they set the goal too high, it's almost like setting the person up for failure. So, measuring small incremental progress, that's really, uh, important. And you mentioned a couple of different kinds of hospitals. If we could go through those again, well, I shouldn't not call them hospitals. I should call them care facilities because
Right.
there's a standard hospital, right?
Right. There's a stand. Go ahead. Well, the standard hospital is going to provide you with acute care services, critical care, ICU, and those would be you could have big hospital like here in St. Louis. We have the BJC healthcare system,
Mm-hmm.
and that would provide you with emergency room services, all types of surgical services, and inpatient and outpatient services.
Mm-hmm.
And then you would have your skilled nursing facilities. And your skilled nursing facilities can be um, different types of facilities. Some can focus on just patients that had stroke. Some
Mm-hmm.
can focus on patients that had amputations, where they're getting the person back to a functional level after they had amputations. Some can focus on patients that
Are we still here?
yes. Some
Okay.
can focus on patients that have been hospitalized for a long time, such as COVID. Patients
Mm-hmm.
were intubated and hospitalized for a very long time and lost their functional mobility. So they're just getting back on their feet. And then some could have had long bouts with illnesses, unfortunate illnesses, and then they're just going into a rehab type situation. And like I said, some could have uh, wounds that require a long time to heal, where they couldn't necessarily do that care at home, but they would go to a facility that uh, could do the wound care, the daily wound care, or some of those wounds might require long term IV antibiotics, such as diabetic foot ulcers that are infected with osteomyelitis. Those wounds take a long time to heal, and
Mm-hmm.
infections in the bone. Sometimes they require IV antibiotics for 6 weeks. So they would send them to a facility to do IVs twice a day for 6 weeks, versus sending them home, because it would be a safer way to do it.
Well,
Um,
I almost think I might need a show just about rehab alone because there's so many different kinds of rehab. But I want to make sure we mention the difference between hospital rehab um, and long term care rehab because those are very, very different. And the qualifications to get in one or the other are different. So, in hospital rehab, which I honestly think they really help you improve a bit better. Um, but the qualification is you have to be able to spend 3 hours of
yeah,
rigorous therapy per day. correct?
Yeah, that is correct. Well, they have a specific criteria
Mm-hmm.
where if you're doing your phrase is hospital rehab, where if
Mm-hmm.
you are recovering from an acute illness and you need to be what they call strengthened,
Mm-hmm.
the requirement is that you be able to participate in the therapy in order to be able to get strong. So if
Mm-hmm.
you have, some people are mentally ill, or some people may have exacerbated conditions, or they're not able to do rehab 3 times. Sometimes it's even 3 times a day, uh,
Mm-hmm.
or 3 times a week. Then they're not able to reach that goal that the hospital has established for them, and they don't qualify for that service, or insurance will say, well, your functional um, independence measure for this criteria, which is your film score, doesn't
Mm-hmm.
meet that criteria, and you still require too much assistance
Mm-hmm.
to meet your activities of daily living. So they're looking at your basic things like how much assistance do you need for eating, toileting, mobility,
Mm-hmm.
transfers, and if you still require more than one person, they're usually measuring, can you do it independent? Do you require one person, or do you require just standby or set up? You just need somebody to set up your meal and you can eat, or if you need 2 people, whatever your criteria is. If you're not meeting those goals, then insurance will say, well, we can't continue to pay for the person to have this type of service. So
Mm-hmm.
then they would be looking at going into long-term care, which does allow, 1 to 2 people to provide those activities of daily living for the individual.
Right. And that those things are communicated to the to the insurance facility by the hospital and the
Absolutely.
therapists and the physicians. Quite honestly, I know sometimes it's on the fence. And so this is where your own advocacy for yourself or patient advocacy, um, family advocacy could come in. So it's just another reason for you to be mindful. I do want to add in this that if you're on Medicare, there's a certain requirement that you have to be in the hospital for 3 days in order for insurance to pay for rehab. Except for in this particular time of COVID, there is a waiver, but who knows how long that waiver is going to last. But the standard rule is 3 days.
That is correct. And I'm, like I said, I'm not an insurance expert, so I would not take my information as the expert level on insurance. But I guess the uh, takeaway here is that your loved one does have to meet certain milestones to be able to qualify for insurance, and
Mhm.
those milestones are measured by documentation that's provided by different areas of the hospital. Most of the time, it's physical therapy, occupational therapy, and they have specific charting that's in the patient's record on whether those milestones are being met.
Mhm.
Um, and so you can ask to look at those records, or you can make some of those observations yourself. But most of the times, it's related to their activities of daily living, like do they
Mhm.
require, 2 people to feed them, to toilet them, for mobility? Can they turn and reposition themselves? Can they put their clothes on, their socks on? Those are the types of issues that they're looking at.
Okay, great. There's been a couple of questions that I want to go back to. Um, the first question is there a place to locate a checklist of questions to ask during discharge? Do you have one of those available by chance?
I will have one of those now that that question is being asked. And that is a very good question. Most hospitals do have a discharge planning list,
Mm-hmm.
and I would encourage you to ask for a copy of that. But we will have one of those, and we will direct you to that information on our website.
Okay, excellent, excellent. And then how about this question? Are there any suggestions to help extend care? Um, I would imagine in the hospital or any setting. Um, is there any suggestions for that?
Well, you have to be working with your physician to see if your loved one is making progress.
Mm-hmm.
And sometimes you can just let them know that you're not ready to accept the patient at home. And it could be because you can't get off work. And that's not going to buy you a significant amount of time.
Mm-hmm.
Believe it or not, um, most short stay facilities are only allowed to accept the patient for a specific period of time. Now, the facility that I worked at, uh, once the patient goes over 90 days, then they're not considered a short stay patient. They're
Mm-hmm.
considered long term care. So
Mm-hmm.
that goes into a different criteria, and it also affects if your loved one is on Social Security, it also affects their Social Security payments. Again, I'm not the expert there. You should get advice from your financial or insurance person on that. But in general, for a couple of days or so, you might be successful, but you're pretty much looking at are they healthy enough to return home, and if you have the services set up for them to be successful when they return home.
So there is something called safe release, right?
Yes, that is correct.
Mm-hmm.
And that safe release is determined by do they have a safe place to go home to.
Mm-hmm.
Um, we're not allowed to discharge patients to the street unless
Right.
they choose to go. So that we would have to provide services for that.
Mm-hmm.
Um, and if there's an issue of safety in the home, uh, the hospital would have to follow up on that. Elder abuse. So there are
Mm-hmm.
some criteria where you're correct that it would not be considered a safe discharge. But prolonging a patient in the hospital, um, and I'll just say this, most of the time the physician is going to be thinking you just need daycare because I'm just going to keep it
Mm-hmm.
real. they,
Well, you know what? I think that's good to bring up
yeah,
because maybe you don't need daycare. Maybe there's a real reason, but if that might be their attitude, you may experience some resistance.
absolutely. So when you're faced with that challenge, you just need to be able to provide the information on why you don't think your loved one is ready, whether it's a medical related reason or whether it's, sometimes people are making repairs to their home. They're getting a roof repaired. That takes a few days to uh, take place. And most hospitals are reasonable to,
Hmm.
to help accommodate those types of situations. But again, more complicated issues would be, homelessness, uh, their health status, neglect, abuse. Those would be more complicated issues on why you wouldn't want to discharge a patient from the hospital.
Hmm. Okay. I love that. Thank you for that wonderful information there. I'm also curious your thoughts on different medications that you might be provided um, and how we can take a look at those things to make them more affordable.
Oh, wow. Medications is such a complicated area for healthcare.
Hmm.
Um, I mean, everybody's so into what's going on politically with trying to reduce medication cost. Uh, and I would say medications in general, um, if your loved one has insurance, there's co-pays involved, and some medications are so expensive that frankly, they're too expensive for you to even afford to take them. But sometimes you just got to know different tricks to make them cheaper. And I'll give you one example. Uh,
Yeah.
some medications that are in higher dosages, It costs 5 and 6 times more than if you get the medication in a lower dose. I'll take metformin, for example. If you
Mm-hmm.
take metformin in a 500 milligram dose, the
Mm-hmm.
cost of that pill is about 20 cents.
Okay.
If you take 1,000 milligram per day, and you get a pill in 1,000 milligram dose, well, the cost of 1,000 milligram pill is about $6.
Hmm.
So why would you pay $6 when you can take two 500 milligram pills and pay 40 cents versus $6 for one pill? But when you're dealing with elderly people on fixed incomes, there's just different nuances that you have to know about medications. For example, can you get it in a generic?
Mm-hmm.
Sometimes those doses, those medications will be cheaper um, if you're dealing with medication that's extremely expensive. Sometimes you can contact the manufacturer and they'll give you a discount where you can pay a certain amount per month. Um, I know that happens frequently with some of the diabetes medications like insulin. Sometimes there's local programs that'll help you afford your medications. So there's different nuances to medications, but I would be my number one rule is if the physician is prescribing your loved one with a medication that they cannot afford, then I would ask, is there if the cost outweighs the benefit, and if it does, ask them how can they get it cheaper. And sometimes the physician will just give it to you. I've seen that happen
Okay.
because they want to see the patients get better. But when you're dealing with medications in general, it's best to be asking questions about, can you get the medication in a lower dose? I'm gonna plug my computer up.
Okay. Very well.
Can you get it in a lower dose? Would that make the medication cheaper? So you
Mm-hmm.
have to be kind of thinking about those things when your loved one when it comes to medications.
Absolutely. So basically, you want to act in partnership with the physician team, the nursing team. Find yourself a social worker. And if one person is telling you no, don't necessarily take no for an answer, because they might think the answer is no or it's not possible, but it could be very well uh, possible. I know a trick that I have used in order to make my mom's medicine a little bit more affordable is even some things that are over the counter, I will have the doctor write a prescription for, because even though the insurance might not cover it, the insurance card, the discount card, will cover it. Like you get a Walgreens discount card, and I'll give you for instance, Claritin is pretty expensive over the
Yes.
counter,
Yes.
extremely expensive. And I had the doctor write a prescription for it. Insurance did not cover that medicine, but the discount card took a great percentage off, and I paid $3 for that medication instead of paying $40.
Absolutely. Absolutely. That's a great way to get your medicines cheaper. I mean, a lot of companies offer discounts, but the nuance is to work with your physician because a lot of times they know things that we don't know about how
Hmm.
to get the medication cheaper, and that usually because they really want the patient to take the medicine.
Hmm.
So they'll be able to tell you how you can possibly get it cheaper. Even talk to your pharmacist.
Hmm.
They'll be
Absolutely.
able to tell you, you know, about the different costs of the different dosages of the medication, and especially if you don't have any restrictions on swallowing and you're able to take your medications okay. So I would just say arm yourself with information. You would be surprised how you can make your medications more affordable by doing it.
That is awesome. Speaking about arming yourself with information, here's a great question. Can you recap the questions to Always ask the hospital and nursing home staff when you're visiting your loved ones.
Sure. When you have a loved one in a nursing home, um, it's always important to ask about how they're eating. If they're in a, uh, I would say, a short stay facility, um, what had how or do they have any bed sores? Because you don't want to find out when they get home if they have bed sores. I would also say, have they had any falls? Are they meeting their goals?
Mm-hmm.
Um, and have they had any changes in their medications? The more you show concern, I feel that the nursing homes will, the patients just have better outcomes. The more concern you show for the patient, they just tend to have better outcomes.
Mm-hmm.
And again, I go back to that medication thing. It's just making sure that their hospitalized medications are going to be adjusted for their home medication, meaning they're going to make sure that they have the right dosages and prescriptions are available. And I would say one of the biggest areas is if patients are there because they have chronic healthcare conditions, a lot of times when they go into nursing home facilities, they miss their appointments for follow up.
Mm-hmm.
So prior to them leaving, it is important to get those follow up appointments scheduled. Because what happens is, for example, if a patient has congestive heart failure, they usually send their medical doctor about every 6 months, depending on how advanced that condition is. If they're in a facility, they may have missed that appointment. They may not get another appointment until another 6 months. So that's a whole year before they see the doctor, and chances are they're going to be hospitalized because of that condition. So I
Mm-hmm.
would make sure that you get those appointments scheduled before they leave the physician, leave the hospital, so that they have the proper follow up. And that's a pretty important thing, so that they don't miss their follow up appointments. And that's how you keep your loved ones at home and healthy.
And I'm so glad you brought that up because you can actually, let's say if they go from the hospital to a facility, you can begin to work with the social workers there so that they can get those follow up appointments while they're inside the facility, and the facility will often provide transportation. So you're
Absolutely.
so you're getting those types of things taken care of. It's all I can say. I can't press on this enough. It's important to work directly with the facility, and I will tell you the biggest thing I learned. Um, if you put your loved one in a facility and there is a resistance to working with you, take them out. Number one, it is okay to take them out. We really do have that power. We're not powerless. And then, secondly, um, if there is a decline in care, so like um, if your if your loved one goes from the hospital to a nursing home facility, you you actually have the power to speak up and say, I want them to be taken to the hospital, but you have to specifically like demand that. And I can tell you right now, they don't like that, but you can demand it because it could be a life or death situation.
It can, and you are your best advocate when it comes to your health care.
Hmm. Hmm. So, um, I know we're rounding the basis to the hour, but I want to get a bit of information in about home health care, because there are some important things that we should know about home health care, particularly the physician. A lot of times, we're the Generation X, um, folks right now, and we're just squeezed. My mother had her doctor for 30 years. And when I tell you they had a love relationship, they were just like arm in arm. They were buddies, okay? But what I found was I was trying to honor that relationship, but the doctor just wasn't the right fit anymore,
Right.
you know? So if you're moving from, um, what I'm going to call healthy independent care to homebound health care, you might have to change some of your physicians to people, to doctors who are accustomed to working with that level of care.
Absolutely. And it's just like anything else. If you require a specialty for acute care, ICU, cardiac care, and there are physicians that specialize in taking care of patients in the home. So you do have to be willing to make those adjustments for your loved one. And then there's insurance, being able to maximize the benefits
Mhm.
because home health, there's a lot of benefits that you have to be able to take advantage of when they're in the
Mhm.
home.
Mhm.
So you do have to be able to make those adjustments with their care.
That's right. And they might not, your regular physician simply might not know. Family, I want to invite you to ask questions at this time. The lines are open to ask questions if you care to call in. So please take this opportunity to do so. You are welcome to do that. I also wanted to bring to light the different kinds of doctors that you can do. I mean, that you can get in home health. I was surprised that you can get an X-ray at your house.
Absolutely. They can pretty much do most of the services in the home as they can do in acute care. Of course, not everything, but there's physical therapy in the home. There's occupational therapy. Um, there is, I mean, some people do dialysis in the home. It's peritoneal dialysis. Um, so there's a lot of services that can be provided in the home.
I did not know you could get dialysis in homes. That's a new one to me.
It's
Wow.
peritoneal. It goes through the stomach. Yes.
Oh, okay.
Yeah.
Okay. See, even that is amazing. You can get IV therapy at home.
IV therapy. That is correct. Yes. Yes.
You know, that is, I mean, that's another really, really good one. You can get your labs drawn at home.
Yes, that is correct. They do pick line, and some people infuse their own IVs, and sometimes they'll have a nurse that comes out and do it. And even wound care, there's wound vacs that get put on in the home. So you're correct. There's a lot of services that can take place in the home.
I got it. I got it. If you have any questions, family, there's the number to call in. I'm sorry, 786-530-1967. That's 786-530-1967. We have an expert nurse here. She's certified in wound care, but the what's so important about April is that she has a understanding of the span of healthcare that someone would need when moving from the hospital to rehab to nursing homes to home care. And I can't say that I believe that we have a healthcare system in America. What I really believe is that we have a healthcare maze, and you don't want to get
That is
lost.
absolutely true.
Yeah, you absolutely don't want to get lost. Let's see here. What is the best approach to ask the doctor to write a prescription for over-the-counter drugs that may allow you to use a discount card? I would just say I want to hear your thoughts, but I was just up front. I just said, you know, this prescription is very expensive. Can you write me a prescription?
Right. I mean, just ask.
Yeah, this message.
Especially some medications that have been transitioned to over the counter, such as
Mhm.
your antihistamines medications, some of your antacids medications. Those are all over the counter now. So I would just ask and just say it's cheaper if I get it through insurance, and most physicians uh, will comply with that. Uh,
Mm-hmm.
I know most will,
You know.
but again, it's about arming yourself with information
Mm-hmm.
about cost and how to make your medicines cheaper. But sometimes getting a prescription, you can pay a $5 copay versus $25 for 20 pills of a
Mm-hmm.
Claritin or an Allegra.
Mm-hmm. Mm-hmm. Let's see here. What is the first step to finding out what in-home services a person is eligible for? That's a great question.
That's a great question. And I would say look at their needs. And their needs is actually it's what the hospital says their needs are, and it's also what you see. Because
Mm-hmm.
the hospital may say that they need assistance with bathing once a week, but you may say that they may need a podiatrist in the home. So if you're looking at all these services, well, if you're looking at all these needs that the patient has, I would say the first step is to talk to the case manager and say what they qualify for, and then start working on how many of these services can be provided in the home. You may not get everything that you need, but I would say start one at a time, just ticking these things off. I mean, for example, if a patient had a bed sore while they were hospitalized, a pressure injury while they were hospitalized, you may qualify for an air mattress in the home, and
Okay.
one that lifts up and down, so that may assist you in terms of being able to take care of the patient. But again, start with the case manager.
Mm-hmm. Mm-hmm. And you want to know what? It is good to maybe reverse engineer things sometimes, like ask the criteria so that you can ask for what you need properly.
Absolutely, arming yourself with information, because a lot of times when you just say, uh, my loved one needs an air mattress, the first thing they're going to say is no. But
Yes.
if you say they have a bed sore, they're not able to get out of bed, they're not able to turn themselves, because that's the criteria for air mattress, then you
Mm-hmm.
might get a different answer. But again,
Mm-hmm.
it's arming yourself with information uh, for a better outcome.
And so it's good to maybe look up the criteria of your insurance company, of online, because basically you have an insurance policy, and they have criteria that must be met in order for them to say yes to a particular item.
Or you can even ask the uh, social worker. I mean, at the
Mm-hmm.
hospital they use CDI coders. I don't know if you get to talk to them, but call the insurance company and ask them.
Mm-hmm.
And then at least you have that information. And it's not about being deceptive. It's about looking at what the care needs are of your loved one in the
Mm-hmm.
home, and being able to, because a lot of times in the hospital, we only see a snapshot in time,
Mm-hmm.
but you're with your loved one 24/7. So you're able to identify things that maybe have been missed, or you could fill in information that maybe the hospital doesn't have. So if you know that criteria, then you're pretty much able to speak the same language as the healthcare provider. And that's basically the position that you want to put yourself in if you're caring for your loved one, is you want to be able to speak the same language as the healthcare provider. And that only can come from arming yourself with information. And sometimes you don't know the question to ask, but
Absolutely.
if
And you want
you
to know what, April? Let's be honest. It's a lot of work.
it is it is definitely a lot of work.
It's a lot of work. Listen, the on hold time alone will will suck up a lot of time.
But the nice part about it is once you have the information
You
and
have it.
you build it, then you're able to pass it on. I
Mhm.
always say I am a nurse who's a fan of health. I want to be able to provide healthcare solutions from heart to heels. And it's all about learning and arming yourself with information so that you can put yourself in a position to help others. And I'm blessed that I'm in the position that I'm in because I can do it every day and make a difference in people's lives. But once you have that information, uh, just think about you can help your neighbors. We're all getting older, and if
Mm-hmm.
we're able to spread these lights of information to our loved ones, our family, our friends, how much helpful we can be in society by having this information.
Absolutely. You know what I love about what you're doing is you're actually putting together these checklists. I think we got it. What do we call it? Rounding the bases. Your first, second, third, fourth um, base, and then you get your grand slam.
Grand slam.
Right, right. Um, because there's so much you need to know. You need to know information for outpatient care versus inpatient care. Outpatient,
Absolutely.
there's so many different kinds of rehabs and facilities and support centers that you can ask for. It is, listen, we could even have a detailed conversation about bandages. We could,
Absolutely. Absolutely. That is
you
true.
know, um, I almost feel like, do you remember the movie Forrest Gump?
Yes.
And the
Yes.
guy started talking about shrimp, and he was just going on and on and on about shrimp. Well, quite honestly, we could go on and on and on about this subject matter to the most minute detail. And quite frankly, I really do think that we should have you back and only talk about two areas of focus, and that is the different levels of rehab and the wound care specifically, because I never know that we kind of touched on LTAC hospitals, but I would imagine unless you've needed one of those hospitals, you probably don't know a lot about them.
Yes. Yes. They are uh, very specialized areas, and I know most people think about facilities, and they really have a bad rap.
Yeah,
Um, and pretty much when you go in the hospital, they're going to give you a list, but that list means virtually nothing because it all depends on who has a bed available that is covered by your insurance.
well, yes. Who has a bed available that is appropriate for
Your
that
loved one
your
that,
loved one?
that will be covered by your insurance, and
Right.
chances are it's probably going to be not the nicest one on the list.
It's tough because if your patient, if the patient's a two-person turn, then that's a whole different level of availability.
Right, absolutely, absolutely. So, even having that information, you're still dealing with maybe two or three facilities, and then you need to be able to vet these facilities and determine, this may be a temporary thing for your loved one until there is another space available. Uh, but, even having that information is going to be helpful to you
Hmm.
because once you go to that facility and they see that you have all this information and you're so educated about the process, evidence base says that your loved one is still going to have a better outcome because you're armed with knowledge.
Absolutely. This, you know what, this, I'm going to ask you for your closing remarks, but this is my a universal tip that I believe that will work anywhere in America for anyone who is over the age of 65. Um, if your loved one is outside of the hospital, or if you are outside of the hospital, Medicare Advantage is a wonderful thing to have. It is awesome. Um, whether you have United Healthcare, Blue Cross Blue Shield. I mean, they have all kinds of things that they're going to give you, even dental care, and they give you money for your over-the-counter drugs. They'll even, what is that, silver sneakers? They'll even give you money for silver sneakers. It is fantastic. This is the however. The moment, the moment that you find out that you or your loved one is in a situation where there's trouble afoot, and there could be a long stay in the hospital, in that Medicare Advantage program and go on straight Medicare as fast as you can, because you do not want to be in a managed care situation, because you just won't be able to get all of the services that you need because it's being managed and monitored. Hashtag limited.
Yes, that is a powerful thing to know, and most people don't know it, so they end up with limited services and not getting the help that they need. And I'll just share this brief story. Unfortunately, I had a niece that passed away
Hmm.
to cancer. She didn't have any insurance. Um, but because of Obamacare, she was able to get a policy through the exchange for little
Thank
or nothing. That was an excellent insurance policy that allowed her to be treated at some of the best medical facilities in the country. So, arming yourself with information, even when you're at a disadvantage for not having insurance, is still a better outcome than not having information at all. But
you.
as a nurse, I've always wanted to just put myself in a position to be used by God, to be used by God to help others. Um, and I'm now so happy that I can be in a position to create opportunities and solutions to direct how I help others in creating healthcare solutions from hard to heals. Because I see that there's so many opportunities for individuals suffering from chronic healthcare conditions and chronic wounds in all communities, but specifically in the African American communities and underserved communities. So I'm so happy to be in a position where I can create healthcare solutions to be able to help others and create better healthcare outcomes. So I'm so happy that Erica had me here today to share my information. You see my dog in the back. Um, had her quiet for quite a while. Um, but I'm so happy to be here today to be able to share my information with you um, and uh, just to be able to be able to just let everyone know that arming yourself with information is the best way to help your loved ones if they are hospitalized and create better outcomes for your loved ones.
Well, excellent. I cannot tell you how thankful I am to have you here on this program. As I recall, you're going to visit us again next week to talk about veterans care.
Yes, yes, I'll be happy to do that.
So you're going to have an exciting journey with us. Get used to seeing her here. She's so knowledgeable. We're going to have her back one, two, or maybe just as a regular. Who knows? Um, that said, I'm going to visit with April backstage for a little bit, but our program is ending. April, I'm so thankful that you've been able to spend this time with us tonight. And I'm excited that you guys spent this hour here with us. We do have another program coming up, and it is just going to be fabulous. I hope you guys stick around or tune in again later. I truly thank you for watching our program thus far. Later on, about 10:30, we are going to speak speak to the idea of what am I missing with Sue Fredericks. She is someone that you don't want to miss. She has us focusing on the idea of energy and how it can change our hearts and our lives. She is a actual therapist that focuses on the restoration of our souls. She also has a expertise in numerology, and sometimes we just have to explore and figure out, why are we feeling jealous, angry, or insecure? And there's a lot of that out there these days. Or how about this, family? Can we really talk to our loved ones that have already passed on? I promise you, it's going to be an amazing show in just a little while, starting at 10:30. I hope you make it back. Nevertheless, if you can't, thank you for watching this evening. And I'll simply say bye bye for now. You're winning. You're winning.